how research in LADA may cure type 1 diabetes. May I call upon Dr. C.B. Sanjeevi.
Thank you very much, respected chairpersons. And I thank Dr. Unnikrishnan and the Chalaram Foundation for the invitation to come and give a talk here. So I'm going to talk about LADA. I may touch upon how this helps in the cure of type 1 diabetes by some serendipitous observations. But I'm going to give you a picture of what kind of differential diagnosis you may have to look at when you have a patient, maybe with autoantibody positivity. So I'm going to divide my talk under these topics. The assay that we do is very important for your interpretation of positive and negative, and assays done by different people may give you different results. So there is some international standardization. Then how do you use autoantibodies to classify diabetes? Autoantibody testing in type 2 diabetes, how much important it is? Should we screen for type 1 diabetes risk? Monogenic diabetes, how is it important? Should we test autoantibody positivity in monogenic diabetes? Using autoantibodies to predict type 1 diabetes. And of course, autoantibody testing in diabetes of unknown type. What is this uncertain type? When we come to that point, you will know. So let's first talk about the autoantibodies association thresholds. So the antibodies to islet antigens are very reproducibly detected and are currently best validated. We have Immunology of Diabetes Society that runs an international workshop. It's a standardization workshop on the autoantibody assay. Anyone doing autoantibody assay in the world using any kind of methodology, whether it is radioimmunoassay or ELISA assay or any other form of assay, need to have their assay validated and get a sensitivity and specificity score. So whenever you report the assay, you need to refer to the sensitivity and specificity for anybody else to follow, whether the testing has been done according to the international standard. So this is very important, and this has been established, and many of the laboratories are following the protocol. So GAD and IA2 are the most commonly measured using radioligand binding assay. ELISA is also used for GAD and IA2, where they have achieved sensitivity and specificity equivalent to that of radio binding assay. So in interpreting islet antibody results, it is important to appreciate the antibody level that represents a continuous variable. Just as much as blood pressure, serum sodium, or pulse, or the concept of antibodies are present as positive or negative, is best a gross oversimplification, at worst misleading. So you could have different levels of autoantibody positivity. What is the cutoff for autoantibody positivity? What is weakly antibody positive? So there are lots of terminologies that are being used. So one needs to really put those terminologies in the context when you are using this for your clinical practice. So the sensitivity and specificity is important. The autoantibody certification is important, the autoantibody testing, and anything that is considered positive based on the calculation of positivity, it's very valuable. One point I need to emphasize here is that if you use antibody assay done on Indian controls, you cannot use the cutoff value to identify positivity in Western patients and vice versa. So if you want to set up an autoantibody positivity cutoff, you need to have a controlled patients, control individuals tested on Indians, and then interpret the results by doing a GAD index and identifying what is positive based on that cutoff, which is mean plus 3 standard deviation, and use that in interpreting the antibody positivity in the Indian patients. So there may be differences in the cutoff if you use one population to interpret the results in some other population. So using the antibody to classify diabetes, now we know that we have so many different forms of diabetes, and the diabetes is increasing more and more, estimated to be more in children and adolescents. The question of adolescents is very important because they don't go to pediatric clinics anymore. So they come to say, if you have an 18-year-old or a 19-year-old with type 1 with diabetes, they will come probably to an adult clinic, not to a pediatric clinic. So the diabetes is increasing worldwide, and the diabetes in children and adolescents is also increasing worldwide. with United States documenting the highest number in terms of number, not in terms of percentage. And you can see next to the United States, India is right there next to it in terms of total number of type 1 diabetics. So it's very important for us to know what is the right way of interpreting the autoantibody positivity. So when you look at type 1 diabetes, which is an autoimmune disease, what determines type 1 diabetes is the presence of a particular HLA that gives high risk for development of type 1 diabetes. Then you need to have circulating autoantibodies. I am only focused on 2 of them here. You have 2 more, which is insulin and zinc transporter. So it's possible somebody could be negative for GAD, negative for IA2, but positive for insulin or positive for zinc transporter. That doesn't mean that if they are negative for these 2, they do not have autoimmune disease. So type 1 diabetes itself is not one disease. It's basically several diseases under the category of the terminology type 1. So it's an organ-specific autoimmune disease, and one important fact everybody should remember, the antibodies do not cause the disease. It's the T cells that cause the disease. Antibody is the result of the disease. So it acts as a very good biomarker for testing the positivity for the autoimmunity. So when we look at the autoantigens, these are the autoantigens. Insulin is the one, glutamic acid decarboxylase, islet antigen 2, which is tyrosine phosphatase present in the beta cells, and zinc transporter, which is also one of the important proteins in the transport of insulin inside the beta cell. So all major type 1 diabetes autoantigens are related to secretory apparatus of the cell, including the zinc transporter, recently identified as additional major autoantigen. When I say recently, it's almost 10 years since it was identified. So these autoantigens identify, or antibodies to them identify autoimmunity. And autoimmunity, when you refer to type 1 diabetes, it's predominantly identified as young people, predominantly identified as children. But now we know that autoimmune diabetes can occur at any age group. But it occurs much more in children than adults. But when you look at adults, we can have a 70-year-old person developing autoantibody positivity, as Susan was talking about yesterday. But when you look at the autoantibody positivity in different populations, you will find that GAD antibody positivity accounts for approximately 70 to 80% of positivity. So if somebody is GAD antibody negative, that doesn't mean they do not have autoantibody positivity. So they have autoantibody positivity to other autoantigens. But if you ask the question, does somebody have either GAD or insulin or IA2 or ICA, they could be positive for one of them. Then you can account for 96% of patients with autoantibody positivity identifying autoimmunity. So when you look at the data, the antibody markers in children of type 1 diabetes, this was the data that was from the Barth Oxford study. The prevalence for autoantibody levels is at the 97th percentile tested among healthy children of 2,854. So the large control population gives you much better accuracy in terms of interpreting the positivity. You find that majority of the children have more or less the same percentage of GAD or IA2 or IAA. But if you look at this particular picture, you will see how many people have only one, how many people have the number of marker positivity in terms of prevalence. More autoantibody positivity identifies much serious form of autoimmunity. Zinc transporter is something that has been now conventionally tested in all populations, in addition to the other 3 that I mentioned. So zinc transporter generally emerged later than GADA, but many of these antibodies seems to have certain flavor. For instance, in an autoimmune disease, we have been following children from birth, 44,000 children in southern Sweden, all the way until they developed diabetes, and the study started in year 2000. And the study is still going on. So what we find in this study is that when we follow up, those who have high risk HLA are followed up with autoantibody testing every 6 months. Those who develop autoantibody positivity are much more frequently tested, not only for autoantibody but for glucose. And these children have not yet developed diabetes. But when you see, you find that insulin autoantibody is the one that appears first. If the insulin autoantibody appears first, the progression to diabetes is much faster. But if GAD antibody is the one that appears first, the progression to diabetes takes much longer. But once they have clinical diabetes, if they are positive, say for instance zinc transporter antibody, by the time the beta cell reserve hits 0, the zinc transporter antibody also becomes negative. So zinc transporter antibody is a clear indicative marker for your end of honeymoon period or the total loss of beta cell function, whereas GAD antibody can continuously be positive even after total beta cell loss as determined by the C-peptide. Maybe 10 years later, even 20 years later after the onset of type 1 diabetes, you can still have GAD antibody positivity. Here is a graph of a study where they had looked at several autoantibody markers together, and you will find that there are combination of positivity. Some are positive for GAD and IA2, some are positive for zinc transporter and insulin antibody, some are positive for different combinations. But if you look at the central circle, 55 of the 223 patients were positive for all the 4. So you can have variety of combinations that are possible, and all these combinations also signify one thing. They all have autoimmunity, but the reasons for development of autoimmunity could be different because of the different antibodies that are forming. So should we test autoantibody in type 2 diabetic patients? The answer is yes. It depends on certain things. So if you happen to have a patient in your clinic who is say 30-year-old or 35-year-old or even 25-year-old who is thin and not obese, you need to think of LADA. So majority of individuals with GAD antibody at diagnosis progress to insulin dependency within 6 years after diagnosis. This was the result of a study, the largest study done on type 2 diabetic individuals, and this implies that there is a progressive autoimmune destruction of beta cells. In this UKPDA study, all those patients who were identified to be autoantibody positive at the time of diagnosis, 6 years later, all these patients were on insulin, showing that there is a beta cell deterioration that was happening. Many of those patients who were autoantibody negative continued to be off insulin, which is an indication to tell you that antibody positivity correlates with the beta cell destruction over a period of time. But something is slowing the onset of the beta cell destruction. So either you can call LADA as separate category that we will talk about, or it is just nothing but a slower manifestation of autoimmune type 1 diabetes. So this is sometimes becomes a semantic discussion. So here in this paper, which was done in Sweden and published a little bit way back, say 14 years ago, is very important because he followed up all those LADA patients, LADA meaning those are autoantibody positive patients clinically diagnosed as type 2 diabetes. Okay? So when their autoantibodies were tested and followed up with C-peptide measurement and how much the fall of C-peptide is there over a period of 7 years and over a period of 12 years, all these patients came up and made themselves available. Amongst patients with phenotypic type 2 diabetes, LADA occurs in 10% of individuals if they are older than 35 years old and 25% of individuals who are below that age. Okay, so the percentage of LADA positivity increases depending on at what age you see the patient. So LADA patients with multiple autoantibody positivity develop beta cell failure within 5 years. That shows the severity of beta cell damage. Whereas those with only GAD antibody or only one islet cell antibody mostly develop beta cell failure after 5 years, maybe a little later, maybe 10 years later also. So the progressive destruction of beta cells takes place much slower in those individuals. So this study shows that LADA is not latent disease, therefore autoimmune diabetes in adults with slowly progressive beta cell failure might be an adequate concept. So the terminologies has been given by somebody, and those terminologies have stuck even though those terminologies no longer have the right meaning that it was supposed to have. So this is an important slide where they have tested the C-peptide level at the time of diagnosis in different categories of individuals. These are controls, these are antibody negative at diagnosis, antibody negative 5 to 7 years later, and you can see at the end of follow-up of antibody positive 5 to 10 years, you will see that there is a periodic destruction of beta cells as signified by the C-peptide level. So when you look at this particular one, the fasting plasma concentration, you find if there is a C-peptide, fasting C-peptide, it will know they have 2 or 3 antibodies at the diagnosis at this point, and their C-peptide level is much lower at 12-year period for 12-year follow-up. So accordingly, with no islet antibody positivity, the C-peptide level seems to be much higher compared to the time of onset of the disease. So when we looked at this set of patients in terms of C-peptide level in Swedish cohort, we found that the mean C-peptide level in type 1 diabetic patients is like this. Type 2 diabetes patients is much larger, and LADA occupies somewhere in between type 1 and type 2 diabetes. But if you look at the follow-up information, you see the LADA as it is shown in the yellow color, the C-peptide level is much higher in LADA patients at the time of diagnosis compared to type 1 diabetes. But if you look at the end of 3 years, the C-peptide in LADA patients is more or less similar to the type 1 diabetes at the time of diagnosis. So there is a deterioration of beta cell. At this point, if you see, this patient might have already been on insulin, either by default or they would have required insulin, or maybe they would have been treated with insulin here as well. So there is a progressive decline of beta cell function in LADA patients. So this is very important for us to know at what age you see the patient and what should be the likelihood of autoimmunity in that particular age group. But it's also important for you to rule out other particular disease. If in this particular age group, say 20, 25, 30, 35-year age group, if you have diabetes in an individual coming to your clinic, you just need to think, if you think of monogenic diabetes, before you do the testing, genetic testing for monogenic diabetes, you need to really test them for autoantibodies, prove that they are antibody negative before you are allowed to, or by recommended to go and test for genetic markers for monogenic diabetes. So this is one of the recommendations. A diagnosis of one of these form of MODY of the young may allow patients to previously thought to have type 1 diabetes and come off insulin. So this particular confusion is avoided. If they are definite MODY and if you want to test them for genetic markers for MODY, before you do that, you must rule out autoimmunity by proving that they are autoantibody negative. So should we screen for type 1 diabetes? So we are doing a very large screening program of children right from birth. It's a huge cohort which is funded by the NIH, and there are 6 such cohorts being followed up in different parts of the world. They form what is called a STEADY study, the environmental determinant for development of diabetes in the young. And that would allow us to predict the disease, and that will also allow us at what time point we should intervene even before they develop the diabetes. So here are some clues. If they are this is a University of Florida study. These are non-diabetic relatives of type 1 diabetic patients. They haven't developed diabetes. So these are the risk score that they have given. If any of the relative without having the beta cell loss is complete, antibody positivity to zinc transporter will also cease. So this is an important thing for us to identify the end of the honeymoon period and current strategy to keep these patients to maintain their honeymoon period. When they develop diabetes, they still have 10% of the beta cell left. But the idea is that to preserve this 10% of beta cells with immune intervention. And if you succeed in this, you will prevent these patients from going in for diabetic coma or diabetic ketoacidosis with the residual beta cell function. So there is a prediction here on the total beta cell loss by measurement of zinc transporter antibody. And this is a very important study. A lot of very interesting results are coming out in this follow-up study. And this follow-up study is also important for us to identify when we have a vaccine candidate, we are close to having few. We need to decide when to give it to them. And if you want to give it to them at the time of diagnosis, already they would have lost 90% of the beta cells. But if there is a way by which we can identify them and give it to them much earlier, we will save much more beta cells from destruction. So this study is addressing all those issues, but it's also throwing up a lot of very interesting information. If the mother is smoker, child is protected from diabetes. I have no idea why this is happening. So such things require further investigation, finding out what's happening here. We don't want mothers to smoke at the pregnancy, but when we have had mothers with smoking habit, something is happening there. So that requires a little bit of, so this kind of information is throwing out to be something challenging. And here in this particular cohort, we found many children developing autoantibody positivity. They haven't developed diabetes. So we hired a psychologist, and the psychologist went to the children family, and they studied 100 children who are autoantibody positive and 100 children who are autoantibody negative were also being followed up. It became so interesting that autoantibody positive children, their families had much greater stress levels than autoantibody negative children. So these families probably had a conflict between the mother and father. There are some stress, other things happening in the family due to disease or sickness. So the children are affected by the stress levels in the family, and the stress here acts as a trigger for autoimmunity in these individuals. You know, that is one of the environmental factors. So very interesting information is coming out. And what kind of antibody testing in diabetes of uncertain type? So what is the diabetes of uncertain type? I'm going to tell you two particular instances. So in individuals who are, say for instance 30-35, when they come to you with diabetes, you need to look at few other things. There is one category called stiff person syndrome. Stiff person syndrome is a neurological disease, and here the patients have muscle stiffness, disabling spasms, and heightened sensitivity to external stimuli. And 1/3 of the patients develop type 1 diabetes. And GAD antibodies, you know, is not only GAD antigen is not only present in the beta cells, but they are present in the cerebellum also. And these patients have 20 times, 30 times higher titer of GAD antibody positivity compared to type 1 diabetic patients. So Stiffman syndrome is something that you need to think about, and GAD antibody titer becomes very important in this particular cohort, and knowing about this is very important. And in a recent publication, they have even measured anti-GAD antibodies in cerebrospinal fluid, and they found to be positive compared to type 1 diabetic patients. So there are very good indications for you to think that when you look at antibody positivity, please check few other things also in these individuals. And this is a very interesting paper. With this information I will conclude. Probably there's one more slide. This is a paper that was published in Lancet as a case report. And here what they have done is they saw a patient in 2006, and the patient was diagnosed with diabetes, and the patient had also developed rheumatoid arthritis. And rheumatoid arthritis was treated with conventional anti-rheumatic drugs. Okay, and then it became apparent that TNF alpha treatment was something that was becoming available, but it was still expensive. So when they started treating the rheumatoid arthritis patients with anti-TNF alpha, the diabetes became better. And at that time they thought it was type 2 diabetes. When they measured autoantibody, they were autoantibody positive. So it was a LADA patient that had developed rheumatoid arthritis, and when you treat RA with anti-TNF alpha, which is an anti-inflammatory cytokine, anti-TNF alpha, it blocks the TNF alpha, then you get diabetes better. So there is an immune intervention that was accidentally discovered in this particular situation to show that concomitant occurrence of rheumatoid arthritis and type 1, they called it type 1 diabetes, has been previously observed. Moreover, the specific association with autoimmune form of diabetes and RA has recently been reported. So all they try to show is diagnosis of LADA relies mainly on seropositivity, and T cells are important factor, and they concluded the anti-TNF alpha therapy may have directly or indirectly contributed to the induction of IL-10 secreting regulatory cells. So here, this intervention with anti-TNF alpha has helped the regulatory cells introduce T cell suppression. So this is a very interesting case. So that way you need to think that in older patients, think of LADA. If you have additional autoimmune disease, think of autoimmune diabetes if those patient has diabetes. If you have thyroid patient, you check for type 1 diabetes also, because you will confront the polyendocrine autoimmunity in many situations. So with this, I thank you very much for your attention. There's an email address. Anybody who wants to write to me, you're most welcome. I have a Facebook page on Thoughts of Diabetes where I upload a lot of very interesting diabetes related articles. You're most welcome to go there and click on it, and you will be able to get all the updates that I find interesting with my comments. And there are a lot of information on LADA that has been published in Annals of New York Academy of Science, which I edited over a period of time. 5 volumes have kept, they have become some kind of a benchmark in terms of reference. So you can find a lot of articles that you might want, and they are all available on the internet. So I thank you very much for your attention. I would be very glad to take any questions.